I think it's just about thinking again about what makes you feel. You should be where you feel. This is something that really, even though, of course, Robin is very, very concerned about you and the outcome of this baby, and your mother also, and your parents. But there's no one more concerned about your well-being and your baby than yourself. And you're the one who will go through labor. You're the one who will have to experience that. So we are in service to you. And we should be able to walk the walk with you wherever you feel like you need to be. And it's not a moment in time. It's not like you have to tell me today or tell me next week, this is what we're going to do. As midwives, we're always thinking, all the way through, from the time we arrive at your house, we're checking on you, we're watching you, working with you. We're always thinking, does this mother or baby have some condition that would benefit from the additional equipment or personnel that the hospital has to offer? And then if it seems like there is, say you're throwing up a lot and it's hard for you to keep hydrated, and you might be that might affect your labor or the progress of your labor. Say you've been in labor a long time. We've tried walking up and down the stairs. We've tried position changes. We've tried all the natural ways to acupuncture, all the things to help your labor, progress, rest, activity, showers, and at some point, the kind thing to do, and probably the judicious thing to do, is to go to the hospital where we can get some pharmaceutical assistance. So we talked earlier about transfer.
Yeah, I'm just wondering as far as like when do you make that call? Who makes that call? At what point?
Yes.
Obviously, midwives.
Right. So that's a great question. I was talking a little bit about the evidence. So as I said, we have very good studies right here in BC by Patty Jansen. We've got studies in the Netherlands, in the UK, and around the world that talks about outcomes. What they've also looked at is what we use in the best studies. They use what's called an intention to treat model, where they keep the people who plan the home birth in the same group when they follow them out to the outcome. So even if they transfer, that way they can compare apples to apples, right? So in BC, when Patty Jansen looked at planned home birth, planned hospital birth with a midwife, so both two groups with midwives, and planned hospital birth with a family physician, she found no real differences. But she found, and most of the studies have found, you talked about interventions, that there's far fewer interventions that women experience, necessary interventions for progress or for safety, if you plan a home birth, even if you have to transfer. So about somewhere between 8 to 12% of people will transfer to the home, depending on the practice. Transfer to the hospital from the home, right? So you intend to have a home birth, and about 92 percent of 8 to 12%. So 88 to 92% of people will deliver normally at home. Of the 8 to 12% of women who transfer, roughly 10% of women, the most common reason, what do you think the most common reason for transfer is?
Just get nervous, or
maybe just like the length, like fatigue, or potentially that they could.
Yeah, exactly. You're right.
It's
length of labor. It's first-time mothers who have a prolonged labor.
Okay.
It's not an urgent transfer.
Oh,
You just get in your car and you go and you hope the bumpy ride does it.
Yeah.
Really, 78% of all those transfers are for failure to progress.
Okay.
So it's not urgent. Urgent transfers are 1 per 2,000. So less, way less than 1%. So
but from a midwife point of view, like if it gets to a certain point or certain lengths, and some other people have saying too, like talk about inducing or getting to a point where it does become a safety hazard.
Yeah.
Right? Is that like, I guess when we get into the point, like, 78% the mother says, I want to go. But at what point do you say, you know what, it's time, it's been too long, we should probably go to the hospital? Or do you even go there?
It's a conversation.
Yeah.
So usually when women plan home births and they're comfortable in their home, it's not them who are saying, they're trying to complete their plan, right? Yeah. So sometimes and that's what you hire us for, we are monitoring the progress and seeing how quickly, and because you were involved, we are telling you, this is what we're hearing. Okay, you were 6 centimeters at this time, and now you're 7, and that means you're making progress. Or it's been longer. We'd like to see you make more. And here's what needs to happen in order for us to stay at home. Here is what we're looking at. The longer you wait, if you have a very tired uterus, you might be more at risk for bleeding. Or, we're worried about you being dehydrated and if that'll affect the baby's well-being. So we're in conversation with you as a family about being preventative. We want to be able to go before there is, something that's an obstetric emergency. Now, as I said, there are unexpected things that happen. We don't plan to do breaches at home.
Okay.
Occasionally you might be in that position. So we as maternity care providers we have the equipment to handle things like bleeding, things like resuscitation, and we provide the same care. At home, the other thing you should know is that you have 2 qualified midwives who come. So in the hospital, you would have 1 family doctor, 1 obstetrician, or 1 midwife, and a labor and delivery nurse. And that labor and delivery nurse may be the same one when you go in, or there may be several shifts of nurses, right?
Yes. Okay.
At home, the standard of care is to have 2 qualified people attend.
Okay.
So you'll have 2 midwives who are both qualified in caring for mother and baby, both qualified in neonatal resuscitation, doing so all because you have 2 potential clients, right? And then at home, the locus of control and responsibility changes a bit too, because the communication that we have with you as a family is very important. So you asked who makes that decision, who makes that call. We make it together. We will inform you about what our concerns are. Usually it doesn't even come to the point of a recommendation because we're in this conversation ongoing. And it should be noted, we've been talking a lot about home birth, but that's true in the hospital too. You suppose you are in labor, you're having a long labor in the hospital. Operative delivery is no one's plan. But if there's something happening, we're concerned about the baby's heartbeat, or we're concerned about, bleeding, or something that would require the additional assistance of an obstetric consultant or surgery. Rarely is it a on the dime decision. Very rarely. Usually it's also a conversation. We're seeing this. Let's change your position. Let's give you an IV. Let's see what we can do. And what happens in the movies of rushing to the OR really doesn't happen often. The OR has to be available. The anesthesiologist has to be available, and then everybody has to clean themselves, and then your body has to be swabbed down. We have to start an IV. We have to give you, if you don't have medication like an epidural already, that has to happen. The nursing OR staff has to be gathered. So, for most surgical births, there's a lead time into it. And rarely, they try to keep available for things that happen unexpected because they look after a lot of high-risk people who may have more quick need to go.
Right.
Or quick need to, say, call the NICU team for a preterm baby or something like that. But that's there as a safety net for healthy, normal, low-risk pregnancy that's term. It's a process wherever you are.
That's a good point too. Obviously we're influenced by media and television and so on, right? So everything we see is rush, go, go, go. And so if something happens, gotta get there immediately.
Yeah, we should be so lucky. Labor babies don't just fall out.
Yeah.
The average length of labor for a first-time mom is 24 hours.
Well, I was thinking more from an emergency standpoint, right? If all of a sudden something happens, we gotta be there. We're fortunate we live 5 minutes away from the hospital, so that's nice, right? But other terms, for me making the decision, I just want to make sure she's comfortable. So as much as it's a decision between both of us and everybody, I guess. If she's not comfortable, then